We can start, boss.
Yeah, yeah. Please.
Good morning, sir. I'm Dr.
Ayush, you can
Ayush. I'll
start.
be
First of all,
yes,
Ayush, just a second.
yes,
Good morning, everyone.
Hello. Hello.
Uh,
Your voice is little interrupting.
Today
Anand.
we have a special now he is moderating today's session. So, morning, boss, and we are
Good
starting
morning.
today's case.
Yeah, yeah.
Ayush, you can start.
Good morning.
uh, 19-year-old female, resident of Alwar, student by occupation, was admitted with chief complaints of abdominal distension since 10 days, abdominal pain since 6 days. She had history of laparoscopic cholecystectomy done around 20 days back. History of present illness. Patient was apparently all right 25 days back when she complained of dyspepsia for 5 days. She was a known case of gallstone disease in 7 years and got evaluated and underwent laparoscopic cholecystectomy under general anesthesia. Surgery details as per the history were duration was 1.5 hours, no intraoperative drain was placed, oral liquids were allowed after 6 hours, and soft diet was started on post op day 1. Patient was subsequently discharged on post op day 1. Then patient started complaining of abdominal distension since last 10 days. She had, which was progressively increasing. It was diffuse. It was associated with dull aching pain all over the abdomen since 6 days. It is non-radiating. It increased in intensity since last 2 days. It was associated with nausea. It was associated with vomiting, which was minimal, watery, non-projectile. Uh, she had history of decreased appetite and generalized weakness. There is no history of yellowish discoloration of eyes, pruritus, or clay-colored stools. There was no history of fever, no history of surgical site soakage, no history of constipation, obstipation, or loose motions, and there was no history of respiratory distress. Treatment history. After admission, patient received IV fluids and medications. She underwent a USG followed by a CT scan with IV contrast. Two USG guided percutaneous drains were placed on 9th of September. Both PCTs drained greenish fluid, approximately 1.5 liters on the day 1. Patient improved symptomatically and her output decreased gradually. She underwent ERCP and stent was placed on 12th of September. Drain output persisted from one PCD and other PCD was removed after a USG scan on 18th of September. Now, patient has persistent output from the remaining PCD, approximately 200 ml per day, and no other complaints are present at present. Past history. Patient has no known comorbidities, no history of any prior surgical intervention. Personal history, she takes a mixed diet, had normal bowel and bladder habit, and no known allergy. Family history is not significant. So, shall I summarize?
Yeah, please summarize.
A 19-year-old
Yes.
female underwent laparoscopic cholecystectomy elsewhere for symptomatic gallstone disease, presented with complaints of progressive abdominal distension and pain since post-op day 10, with no history of jaundice or fever. She underwent USG guided PCD placement followed by ERCP and stenting, and now has persistent drain output approximately 200 ml per day from the PCD.
What do you feel provisionally what she is having now at present?
Yeah, based on the history, patient seems to have a cholecystectomy bile duct injury with biliary collection, with a persistent low output external biliary fistula.
Injury means how we are sure that the bile duct has been injured during polycystic. It can be
Uh,
simply a blowout also, it can be some aberrant duct leaking into the from the gallbladder, but that may be.
uh,
So why we
just
are
suppose.
more of suspicion of the injury?
More suitable, I think, term would be a post cholecystectomy bile leak,
Yeah,
and
that we can use because it's a broad term. So just by leak, and we are not sure at present anything has been injured or not.
yes,
So have you gone through the pre-operative symptoms of her stone diseases?
uh,
She is 19 years. And last
Yes,
7 years you have mentioned means
yes,
at
sir.
the age of around 12 she developed this stone.
Yes, sir. At that time, she similar complaints were there. She had mild bloating and dyspepsia symptoms, but they were absent in this duration. And at that time, the parents had decided to manage it conservatively. But this time, since the symptoms reoccurred, they got evaluated and underwent laparoscopic cholecystectomy.
You mean to say over the period of last 7 years she was continuously suffering,
No, sir. She was asymptomatic. This
intermittent.
was the second. Yes,
She
this
was
was
apparently
second.
asymptomatic.
Yes, sir.
There was no past history of any acute cholecystitis or any other admission for these stone diseases.
No, sir.
So this indication for this cholecystectomy, which was she underwent, was the biliary pain. That's what
Sir,
from your history.
Sir, it was more of dyspepsia, nausea, vomiting, upper abdominal bloating, but as such, no
Okay.
pain, fever, or jaundice was there at present.
Okay. Have you got information by history? How many stones she was informed she is carrying for last 7 years? Multiple, small, single.
Uh, Sir, roughly the parents told that the size of the stone has increased, but previous and a
Okay.
current USG scan was not available with us.
There's no past the USG available.
No, she was just told
Have
that
you
the size had increased and she would have to undergo a cholecystectomy.
so likely they are saying one single stone is there and size has been increased.
Yeah, likely, sir.
That's that's what from history we can. Yeah.
Yes.
Do you think that is the common age group at the age of 12 years she developed the stone diseases, GST,
Uh,
gallstone disease?
no, sir, this is not a common age for a gallstone disease. Uh,
Yeah, what is the common age group?
So usually it is a middle-aged woman, 40 to
Mhm.
45-year-old woman, we say, which who is overweight, and these are
Okay,
uh,
fine. What can be the reason in this second decade?
uh, multiple reasons can be there. It could be more blood, depending on since we are assuming it's a single stone, but there can be multiple stones. It can be some blood disorder like sickle cell anemia, thalassemia, which can cause this disease in young patients. There could be
Okay.
some
Yeah,
abnormal insertion of the biliary tree into the pancreatic duct, which causes a reflux and causes stone stasis.
hematological disease is one of them.
Yes.
Fine. So operative history, you told only 30 minutes the surgery lasted.
1.5 hours, sir.
1.5 hour surgery lasted.
Yes, sir.
So it was done some outside center.
Yes, sir.
It was the timing of surgery. Was it in the evening surgery or some late evening surgeries?
Uh,
Or is it a private center, government center? Have you inquired about this thing?
it was a private center, sir. She was admitted for 1 day prior to the procedure, and I didn't
Okay.
ask about the timing of the surgery, likely in the morning, I would assume. But I did not
Okay.
ask.
Because at many centers, the patient admitted on the same day as a date care of surgery, and they are posted in the evening or late evening, probably 7, 8 p.m. sort of.
Right.
So she admitted 1 day before, and next day she was operated.
Yes, sir.
Fine. Have you taken surgery? Any blood transfusion was given during his surgery?
Uh, no, sir. Blood transfusion was not given.
What do you think? What is the implication of this blood transfusion to the death system?
Difficult surgery with an intraoperative bleeding could implicate that in panic or in some haphazard clipping might have to be done to control that bleeding, and that could cause further bile duct injury. And vascular injury would have its own other complications.
Which artery you think will be lead to this much bleeding, which may lead to the blood transfusion? During,
Right hepatic artery, when it transverses very close to the
yeah,
cystic duct and the
commonly right hepatic. Otherwise, any hepatic supply from middle lobe, if there is injury, it can be massive bleed, which may lead to blood transfusion or increased duration of this surgery. So
yes, sir.
drain was not kept according to you, drain was not
No,
kept in the surgery.
no, sir.
She went, she was discharged on day one.
Day one. Yes, sir.
So, what is the importance of this short history and very straightforward history?
Sir, it means that she did not have acute, likely she did not have cholecystitis or associated pancreatitis, which might have complicated the surgery. We can assume, uh, and the cause of this pain, abdominal distension, might not be some underlying disease that was going on.
Okay, likely the cholecystectomy was not very difficult, or maybe it was the surgeon was sure it is very straight. He has finished
Yes,
the surgery without any adverse event, and he has not kept any drain. And the very next day, the patient was sent back home. Then
yes.
she was readmitted for
She
further
was not.
intervention.
Uh, she got admitted to our center later.
She was referred to you when she developed further symptoms.
Yes, sir.
Okay, fine. So two PCDs was put.
Yes, sir.
They drained.
Uh,
They drained bile.
yes, sir.
Okay. You have mentioned one intervention also.
Sir, an ERCP was done after
Yes.
3 days after the PCD placement.
Fine. The PCD was placed first and followed by the ERCP.
Yes, sir.
So, what was the finding in the ERCP?
Sir, I have shared the investigations later on. Shall I?
Later on. Fine. We'll go after the this thing. So, ERCP done and stent was placed.
Yes.
Fine. Now, patient has only one PCD at present. One
One
was removed.
one was removed after a USG scan.
Okay. So, by history, you feel it's a post-cholecystectomy biliary leak.
Yes,
So, if you have to put in an order, what you will put in the frequency of the its occurrence? Is a leak from the some cystic blowout or injury, which is more common?
cystic blowout is more common, sir.
Okay. Injury will be the
Second one.
on the second lower on the provisional diagnosis.
Yes, sir.
Fine. So please show the investigations what she underwent.
Sir, general examination.
Yeah. Okay.
Patient was conscious, alert, and well oriented to time, place, and person. She is a thin-built patient with a BMI of 17.5 kg per meter square. She was febrile, pulse was 82 per minute, normal rhythm, respiratory rate was 20 per minute, SpO2 was 96% on room air. Blood pressure was 100 by 70 millimeters of mercury. There was no evidence of anemia, jaundice, cyanosis, pedal edema, clubbing. JVP was not raised, and no palpable lymphadenopathy was there. On abdominal examination, on inspection, abdomen was flat, umbilicus is centrally placed, outside scars were seen, all quadrants were moving with respiration. There was no dilated veins or visible peristalsis seen. Hernial orifices appeared normal with no visible cuff impulse seen. Spine was normal. A percutaneous drain was seen in the right upper quadrant in situ, which had 70 ml, around 70 ml golden yellowish clear fluid was noted. On palpation, abdomen was soft, non-tender, no guarding rigidity, no organomegaly. Liver span was 11 centimeter, and per rectal examination was essentially normal. Respiratory, cardiovascular, and central nervous system were within normal limits. Uh, Sir, my
Yeah. Please.
provisional
Some.
diagnosis. Uh, sorry, again, to summarize, 19-year-old female underwent laparoscopic cholecystectomy for symptomatic gallstone disease, presented with complaints of progressive abdominal distension and pain since post-op day 10, with no history of fever or jaundice. She underwent a USG-guided PCD placement, followed by ERCP and stenting, and now has persistent bilious output from the PCD, approximately 200 ml per day. My provisional diagnosis for this is a post-cholecystectomy bile leak with controlled low output external biliary fistula, status USG guided PCD and ERCP guided stenting. Uh, these are the investigations, sir. Her HB is 10. Counts are slightly on the higher side, 10,500. Platelets are adequate. electrolytes are 133 and 4.5. Creat is zero point 0.5. INR is slightly higher, 1.69. Sir, we have two LFT reports with her. One was
Okay.
pre-ERCP and post-ERCP. Before ERCP, the total bilirubin was 1.6, and after it came down to 1. Direct component was higher, which was 1.1, and it came down to zero point 0.5. SGOT and SGPT slightly increased after the ERCP, and ALP went down. Her serum amylase and lipase were normal. One USG abdomen we have prior prior to the CT scan, which was suggestive of an over-distended stomach, query abdominal compartment syndrome. It was an outside USG, and no further details were available for this. So this is the CT scan for this patient.
Please elaborate the findings.
So there is this describes a large cystic collection uh, in the less possibly in the lesser sac, extending up to the perisplenic area and perisplenic area. Uh, the liver and spleen appears normal here. There is a opaque shadow going here, possibly a Riles tube, which continues here with a gas shadow here, which is suggestive
Okay.
of a compressed stomach.
Okay. The collection seems anterior to the stomach and
Yes, sir.
compressing it. And that's why they probably mistook as a distended stomach in the
Distended
ultrasound.
stomach in the yes, sir.
Okay, fine.
Another opacity is seen here, which possibly could be the surgical clips,
Okay,
and there seems to be some collection in the gallbladder fossa, which is in here in the liver bed as well.
okay,
There is mild pelvic collection as well.
okay,
So the report was a large, thin-walled cystic lesion in the gastrohepatic and perisplenic region, causing marked compression of the gastric fundus and porta, resulting in upstream mild IHBRD intrahepatic biliary radical dilatation. There was no hemorrhagic or solid component seen. Suggestive possibility of a bilioma was present, and small fluid pocket is present in the gallbladder fossa.
okay.
Uh, it was followed by ERCP. The
Hello. Wow.
guide wires
Mhm.
guide wires were placed in both right and left hepatic ducts, and two 7 French 12 centimeter plastic stents were placed. So
Okay.
this is the picture. This is the picture.
Of
Of
cholangiogram.
yes, sir.
So where the injury or leak was detected, any leak was detected in this ERCP?
Actually, they did not mention,
What do you think?
sir. Although they have not mentioned leak here.
They did cholangiogram.
Yes, sir. They have not.
Cholangiogram obtained and no leak seen.
Yes, sir. But sir, on viewing this cholangiogram, there appears to be absent right posterior duct here.
So that looks cystic duct. Right
Sir,
posterior and left is seen. Left is probably draining. Left duct is joined by the right anterior.
okay, this one.
And this one, there are three ducts you can see, three large
Uh,
ducts. What you are
yes, sir.
pointing it out, probably. So how will you see that what you are telling is right is missing right posterior during cholangiogram? How you will come to know that? And this medical gastroenterologist doing this retrograde cholangiogram. So at that
Sir,
time, can we able to know?
it depends on the type of injury. If it has been cut off from the common biliary channel, then it would be difficult for them to uh, see it on the cholangiogram.
I was asking aberrant duct leak. Suppose right
Uh,
aberrant.
right, sir.
So that leak we are suspecting. So will it be detected by cholangiogram at this time?
No, sir. It won't be detected. If it is in the less likely, sir. If it is in the continuity with the like ducts of Rushka, if it is in the continuity, then we may see. But if it is separated from the, it's an isolated duct, then we won't be able to identify it on the cholangiogram.
See the when you do cholangiogram, it's complete liver is opacified by the bile ducts. The
Yes, sir.
biliary tree occupies complete liver, means all ducts are in line with the biliary system. Some posterior segment, if are not opacified during, then likely it may be injured aberrant duct, which is not in continuity, which is not draining into the system. So we can have that idea from this cholangiogram. Here it seems complete, anatomy is complete, both right and left is joining. So leak was not seen, nor from cystic duct blow or neither from any other duct.
Yeah.
So where it can be? Do you think where it will be? The leak from where it came?
So it is likely to be an isolated duct, mostly some
Okay.
aberrant subsegmental duct or
Or
aberrant
cycle
some
ducts,
cycle duct. Yes, sir.
maybe from gallbladder fossa.
Likely, sir.
Okay. So any further investigation now? What you will plan from now onwards?
Sir, in this process, I would have liked to have a MRCP done for this patient, which would have again given a better idea about their isolated system. But since this was not done, and it is a low output fistula, we can probably wait for it to get controlled by itself. If it doesn't get controlled, then I would like to go for a MRCP first to see
Okay,
the isolated system.
fine. At present, you will plan conservative management.
Uh,
That's what you will.
yes, sir. It's a controlled
Now,
low output.
yeah. Since his output has come down, output has been reduced.
Yes, sir. 200 ml.
Fine, fine. So one more thing I just want to ask: in your abdominal examination, you have mentioned the rectal examination
Yes, sir.
in this patient. So why it is necessary to do rectal examination? This particular bile duct
Sir,
leak patient, bile injury.
if this was to complete the examination, also if there is a pelvic collection or an ascites aboginus or something could be felt, which an undrained collection in the pelvis could be felt, and that could be the reason for the continuous output from the PCD as well.
You want to say for collection and collection to feel any collection.
Uh, yes.
What
Yes,
stool
sir.
color has to do with the bile duct injury, or fingers stained with some color of a stool,
So
yellow color stool?
if
Yes.
it is a complete cutoff of the if it is a complete cutoff of the common biliary duct, then the clay colored stool with this duration, a clay colored stool would have been
Okay.
suggestive of a complete cutoff.
Yes, so that is the significant. If there's no biliary entry continuity, so stool color won't be yellow.
Yes,
So that's one of the reason for any per rectal examination or asking any stool color change in the patients with the biliary leak post surgery. Fine. So suppose these patients after now she is in the second week of surgery. Okay. After
yes, sir.
another 2 weeks, she is coming to you and the fistula, external biliary fistula remaining around 80 ml, 200 ml,
Yes, sir.
and no other symptoms patient is having. So would you like to extend further, or again you would like to investigate at that time?
Probably I'll do a simple USG first to see if there is any collection getting if any other if it is getting collected in the abdomen, and that could be the reason for the decreased output. Once I have ruled that out, then I would probably go for an MRCP which was missed during this duration of admission, to see if I can detect the site of leak.
3 सेंटीमीटर नीचे से तो ना नीचे से लेके आओ, लाइक नीचे से ले लेना, कोई दिक्कत बाहर से नहीं।
So you are going to plan MRCP now.
Uh,
So fine. So do you think any functional scan or any HIDA scan has any role in these
yes, sir.
patients?
Scintigraphies are mostly useful in cases of aberrant injuries and isolated ducts. But cost is an issue, and they are not very specific anatomically. We can just be able to see that there is an evidence of active leak uh, from the system. So my preference would be MRCP then uh, scintigraphy.
So MRCP done and it shows a leak from a right posterior duct, aberrant duct leak, which is not in continuity system, and she is already stented and brain output is remaining 80 ml, say around 100 ml. So further management, what would you like to do now?
Sir, it is still an early period and it is a controlled fistula with no other symptoms. I would still like to manage it conservatively and follow the patient further.
Okay, how long do you want to achieve? How many weeks you want to? Suppose say another 2 or 3 weeks, situation remains same.
So it is generally assumed that up to 3 to 6 weeks, 3 months should be given for an external biliary fistula. Any intervention before that do not have as good as an outcome as a delayed repair. And
Okay.
if even after 3 months it is not getting control, then I would like to plan for a surgical intervention.
Fine. Surgical intervention in the form of what will be your plan?
It will be a biliary enteric anastomosis with the injured duct would be preferred in this situation, given that we can intraoperatively identify the leaking duct.
See, the segmental ducts mostly they heals with the strictures with time. Most of the time, they heals. So Roux and Y hepaticosis nostril or biliary enteric anastomosis usually not required. The segment undergoes atrophy and atrophy, hypertrophy, and patients usually they remain asymptomatic. So very few patients in those the bile continues to be remaining high and suppose segment right posterior large segment is draining those bile and bile output remains high and persistently high. Those selected patient may require this biliary anastomosis. Otherwise, most of the patients after putting a stent and control of the biliary fistula, they heals very well.
Yes, sir.
Fine. Hello.
Yes, sir.
Yeah,
Yes, sir, you're audible.
fine, fine. Fine. So, any classification you are aware about the commonest use classification? Which classification?
Strasberg classification is the commonly used one, sir.
Okay.
And as per the Strasberg classification, this would come into type uh, type C, a type C injury,
Okay, which is not in continuity.
which is not in continuity, and there is an active leak present.
Okay. Similar case scenario. If you
Yes,
You
sir.
are operating as this patient, and while peeling off the gallbladder from the cystic plate, and you find some minute bile duct or bile leak, what you are going to deal with that? That area is from the fundus or body area, and you have flipped the structures, and you got some minute
Uh,
bile leak
Ideally, it is advised that in
during
such
surgery.
yes, intraoperatively, ideally it is advised to have an intraoperative cholangiogram to assess the continuity of the duct to identify if the anatomy of the ductal system. If it is an if it is a less than 3 centimeter isolated 3 mm isolated duct, they usually
Mm.
tend to get healed by themselves, and we don't have to do anything for those. If it is a bigger duct with the system, then we have to intraoperatively repair the patient if the expertise is available.
Most of the cases, when you find these ducts, they are very small, not very large. It's common to find small ducts, very ductile radical draining into the gallbladder. You can find out the bile on table. So they can simply sutured or can be clipped also. And putting a drain in those particular cases, can put drain in these selected patients and can come out. So any other classification, our own classification, you are aware? One
Uh,
is Strasbourg. You told there are many classifications, like Hanover.
Hanover's is there, so Amsterdam is
Yeah.
there, Lau classification is there, McMahon's, Pendays.
Any Indian classification? Are you aware?
Sir, VK Kapoor sir's classification is also
Yeah.
there.
A very simple and practical classification given by himself. So, what is that? Any idea about
Sir,
that?
I have a rough idea. It deals with whether a major or a minor duct was injured or not. Then they have given sub
Hmm.
alphabets that whether it was involved, yes, no, whether vascular injury was there, yes, no. But sir, I'm not completely versed with that.
It's BCD classification. Just to go through very practical. These by leak and C circumference involved. D duct whether significantly that just now we're discussing small duct less than 3 mm. Duct injured is significant or not? Fine. We almost finished the case. So any surgical.
I would like to add
Yeah,
something in this. First of all,
please.
you have missed the biopsy report of this patient. You have not informed during the biopsy report. Whatever will be the biopsy report, you should have informed in your history. Okay.
It was
Another thing you have missed in this intraoperative event, as the Dr. Gajendra suggested, intraop was eventful or uneventful. As you have told the duration of surgery was 1.5 hours. That means that usually the lab chole finishes in half an hour. They took approximately 1.5 hours. That means something was happened intraoperatively. Mostly it is bleeding. So you should have asked the relative either was the blood transfusion or the surgeon informed to relative regarding the bleeding or not. Okay.
yes,
Another thing is that you have rightly pointed out regarding the after putting the PCD, they should have done a imaging in the form of MRC. They shouldn't not to do that directly go on the for the E. And the ERC, as you can see in the ERC, there's a some below the canvas. And the image you are showing in this diagram, there's a
yes, sir.
some influence.
Uh,
Probably,
Sir, your voice is not audible. Sorry.
yeah. Now you can see there's some irregularity in the just you see there's a some narrowing.
Yes,
Okay,
sir. Yeah.
maybe because maybe the clip was placed right to that and it was divided and placed very near to the CBD. Maybe there's a possibility. I
Okay.
don't know what exactly it is, but there's not smooth. This smooth duct some regularity I can see here in the pulse below conference. Okay. So something was happened here, and I'll show you. I have a image, classical posterior sectoral duct injury. When we have a such type of injuries, when the patient comes to the come with follow up, and he is having bile output approximately 100 to 200 ml per day with normal color stool, that may be something, some continuity is still there, and some posterior sectoral ductal injury has occurred. So in these cases, if we want to evaluate these patients, so we can do two things. Either we can do diet sinogram, with the help of this drain, we can put a contrast, and it will give you the image, the correct continuity with the biliary tree, or the MRC. If we, I'll show you the image. Just stop share your screen. So I'll do that. I'll share mine. I'll show you the image. Now you can see this is the image. You are able to see this image.
Yes, sir.
Yeah, we are able to.
The
We are able to see
classical
the image.
posterior sectoral. Okay, and with the right anterior sectoral duct continuity with the left duct, and they're forming the CHD, and posterior sectoral duct is injured and the segment narrowed. You can see here. So in the management of the sectoral ductal injury, there is still confusing literature regarding management. As Dr. Gajer suggests, most of these patients, after the posterior sectoral ductal injury, these lobe get atrophied, and no further management is required. But if the patient develops these features of cholangitis in the form of or cholangitis abscess because of the undrained segment, then you have to drain this segment. Initially, you need PTPD, and after that, you may require Roux-en-Y hepatico this post-exploratory duct. Anything would you like to add, Dr. Gajendra?
You are right. So few selected patient may still require because output remains 300-400 ml and persists beyond 2-3 months. We have operated case also like right posterior duct, isolated injury, and bile continuously leaking as external biliary fistula, and not settling, and patient having a recurrent bout of the cholangitis.
So, if any participant have questions, they can ask. They put in the chat box. Or Ayush, would you like to ask something? You can ask if you have any queries.
Sir, in the literature and other things, scintigraphy has been repeatedly given for these cases, but it is not always practically possible to get a scintigraphy done. So, what is the experience with scintigraphy in these cases, practical experience? So, HIDA scan, mebrophinin scan, and other things have been mentioned in the literature.
The IDA scan is a functional scan, is a hepatobiliary immunodiacetic acid scan. And one thing is availability, it has to be available. Second thing is cannot anatomically locate the injury. It will tell you leak is there, and or that is either completely the pressure is out of the biliary system and whether it's entering into the gut. So continuity will we have an idea about the continuity biliary, but the anatomical location and to specify that level of injury will not be done by this scans. So practical utility for managements are not very much as we say. For that, we need MRCP to know the level of injury that decides on our further management. One thing I just want to add that whenever we at the tertiary center we get the patient of the bile leak. So main thing leaking is operative notes. Surgeons, whoever is operating, most of the time the notes will not be provided. There are many things which has to be included, like how many structures clipped during the surgery, what was the right upper quadrant area having any adhesions, difficulty during surgery, any bleeding, 2 structures clipped, 3 clips, and the cut section examinations of every gallbladder, whether there were small stones, multiple stones, mucosa normal. Implication is when you operate a patient with a single large stones, unlikely there will be cystic blowout. When you have cut section, you have small stone 4, 5 mm, 3 mm. And when you handle the gallbladder during cholecystectomy, small stone may pass into the CVD during surgery. It may get stuck at the lower end. It may lead to the cystic blowout. So these intraoperative information and preoperative information, both we have to collect during history. Main thing intraoperative is most of the time missing, and we have to collect everything from the patient, the relatives, or investigations. So the notes has to be included completely, the critical view of safety achieved or not achieved, structures flipped, any untoward incidents or not any variation in the surgery was included. Especially in your patient, it was 1.5 hour surgery. Dr. Anand has pointed out this is little extra time they have took to do surgery. And timing also matters in when we see the surgery performed in the evening or late evenings, or performed on very young patients or very straightforward gallbladder, say you say. So there are chances in the evening time they are in a hurry, somebody is doing some flipping or classical duct injury, which is, is the commonest injury.
So first, the role of high scan in the bile duct injury. Basically, high scan suggests biliary enteric continuity.
Yes.
Only one thing, biliary enteric continuity is maintained or not. Nowadays, many surgeons, most of surgeons are not using the high scan, but the high scan usually SGPGI people use. They use the high scan, and they only the significance is this: if the patient is having bile leak, and if you want to confirm this patient should go invasive treatment like ERC, so you should confirm the biliary entry continuity is maintained or not. If the biliary entry continuity is maintained, then the patient we can subject directly for the ERC. Cases who have bile leak, these patients have collection in peritoneal cavity, we directly cannot subject this patient to MRC because the fluid collection will interfere with the reporting of the biliary, or this biliary anatomy will not able to confirm where the site of the injury. So in these patients, we have to drain the collection first. And one of the our participant asked regarding this MRC or MRI. So the right for the question is, do we have to drain the bilioma before MRI? This is correct. We have to drain the bilioma before MRI because this fluid will interfere with the reporting, or the biliary anatomy. We will not be able to confirm the site of the leak with the presence of collection. Okay. So the HIDA, the biliary entry continuity is maintained or not? The thing is here. And can you please mention the other classification system for the bile duct injury, as the Dr. Ganesh Bhatt suggested, the Dr. VK Kapoor classification, the BNC classification? Both, please, could you please tell again the classification name, if you the one of the or the BNC classification name, Satish? BNC classification was
Yeah, it's a BCD classification. 2008
BCD.
paper
Okay.
was there from this BCD classification. B is bile leak, yes or no, means dry or wet injury. C is circumference inward, full or partial. And D is duct, significant or insignificant duct injury. So this
And
is
another
basically management based practical, you can say, classification. Very simple also.
and another participant iPhone, I don't know what is the name. I asked, shall we send the same bilioma drain fluid for culture? We always send the fluid for culture whenever we drain any fluid collection. Always. And do we have to do the MR angio for this patient? And in this patient, we have a narrowing at a cystic duct junction. How to treat this? And the question, you chat box, you can see the question, Dr. Gajendra, as this iPhone.
Okay, fine.
Last question.
Uh, I think question is to narrowing at the cystic duct junction. Okay,
Uh,
I haven't seen, but you just elaborated. So that may form a stricture. We have to biochemically follow the patient, basically this patient. At present, she is stunted, particularly this patient, so she won't have any symptoms. So after stent removal, we have to see whether she developed any jaundice or any raised alkaline phosphatase or any raise in the GGT. So we have to follow patients and your development of any symptomatic jaundice or something. So it may lead to biliary stricture, and it can be dilated also because continuity is maintained. So the further management depends upon the future symptoms and presentation. Stricture formation can be there. Another thing, I just one thing more want to add is the changes in the LFT post lab cholecystectomy. So we should be all should be aware. Any normal patients, we do cholecystectomy and we check the LFT on day 1 or day 3. There is always alteration in the LFT. It won't be normal. The reasons are given like effect of the pneumoperitoneum, effect of the anesthetic drugs. There are changes in SGOT, PT. It will be raised twice or more, and raised in bilirubin also. Alkaline phosphatase changes are less likely, but LFT will not be normal in any given patient. So LFT, these changes are considered normal as a part of the post procedure. These changes also we should be keeping in mind when you are dealing with some leak and you have some altered LFT reports. So they are normally changed in all patients post laparoscopic cholecystectomy.
One thing is confusing here in Dr. Ayush, your patient. Just after doing the ERC, there's a reduction in the alkaline phosphatase. This shouldn't be there. As we know, the patient having
Yes, sir.
right posterior sectoral ductal injury, why there is a reduction in the alkaline phosphatase? Number one. Number two, why there is increase in OTPT, SGOT, OPT? We know that this is not the obstructed segment. The segment is different. So this is a shouldn't have a correlation with the ERC procedure with the change in the LFTs pattern. If there is a reduction in the alkaline phosphatase after ERC, that suggests there may be some stricture or maybe some narrowing in the duct in which the stent was placed. This is my
Yes, sir.
thought.
Or could be a sir external compression from the bilioma that got relieved because of the stent
That was drained previously. That was drained
previously.
previously.
Yes,
The
sir.
ERC was done after the draining glioma.
Yes, sir.
So this should have no relation with this probably, but we can confirmedly say after removing the stent, we should do an imaging when the bilioma get stopped or there's no drain in the no fluid collection in the drain. So we should repeat imaging in the form of MRC, and then after that we can confirmedly say, or we can do a sinogram, so we can get to know the exact ductal site of the injury. So thank you, Dr. Gajendra, for moderating today's session, and thank you, everyone. So we are closing the session today's. Okay.
Thank you, sir.
Thank you, Dr. Anand, for this opportunity. Thanks.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, Ayush. Ayush, thank you.
Yes.